Okay, so for this part of the video, we've already talked about the priming and the pressure and the position. For this part, I want to just talk about why we have an art line in the first place. It's only ever used for critically unwell patients we would have in Resus, usually on their way to ITU, and the team want to have eyes on blood pressure really at all times. The monitors that we have will give us 1 minute intervals for the patient's blood pressure on the sort of manual monitoring method, but once you have an art line in, it's really very continuous and it's completely accurate, and we can see very clearly what the patient's blood pressure is doing. When we have a patient with an art line in, it's really important to monitor the patient, so not only keeping an eye on the blood pressure but to actually monitor the art line. And really a patient with an art line in should never be left unattended. You're essentially looking after at that point a patient who's critical care, and in terms of their art line we really need to keep an eye on the site itself. We've already thought about infection control and the risks of infection when we're putting the line in, but once the line's in we're also keeping an eye on other things that could go wrong. So for example, the risk of hemorrhage is obviously pretty great. We've just put a hole into an artery and we've added a little port into that artery as well. Should our art line set become disconnected from that arterial line, obviously your patient could bleed quite rapidly, and that would be a very dangerous situation. The other risk as well is risk of clot. So if that art line was to somehow clot up, obviously the circulation would not be getting then to the patient's hand, and that would be a grave risk to that limb potentially. So keep an eye on the patient's hand for a change of colour. If the limb was to go white or blue, it's really an emergency if that hand became ischemic in any way. What you should do at that point is just essentially what's gone in there is very much like a venous cannula. All you would need to do is put some extra pressure on there and quite quickly remove that art line. You're not going to kill your patient, do your patient any harm. We don't give any drugs or do any life-saving via the art line other than monitoring. So you're not going to do anything awful and any harm to the patient, but you may save their hand if they have suddenly lost blood supply. Get the art line out and let a doctor know right away that that's what you've had to do because of that reason. The next thing we're going to talk about is how do we zero the art line, and that's something I as a nurse I know over the years heard a lot of talk about. People say go off to air onto patient and I never really understood it. I'm going to try and explain a wee bit simply what that means, and also even if you don't feel confident enough to do it, at least you might understand what ITU doctors are trying to do when they do it. Okay. So we talked when we were priming the line about the little air port, and if we have a look again just at the little port beside the transducer, really when you're zeroing, what you're trying to do is allow the transducer set to feel what atmospheric air is doing at that particular time, what's going on in the environment in terms of pressure. So to zero to the patient, what you need to do is use this little bit for the art line and this transducer to be connected to the machine so they can record and see what any pressure is doing. You need to have one of these cables, which will also be in the bottom of your lines trolley, and also there's a bucket at the side of the lines trolley with quite a number of these in it. I've been told these new grey ones are more reliable than the old white ones, so try and find yourself a grey one if you have a choice. That bit of the cable, I don't know if you didn't notice before, that also comes in the original set. So that white part of the cable with that fancy end on it comes in it, and only one end of this grey cable will fit in there. So you'll very quickly, if you don't remember, you'll very quickly be able to figure out which bit goes where. The red end then will connect to the red port at the back of your monitor. And the art line one actually is on this. I don't know if you can see, Gavin. I'll try and go around a wee bit more. Can you see there? So the art line one is actually this one on the little back plate, the same as where your CO2 monitoring is. So on that back plate you have the actual art line monitoring. And when I plug this in here, and again it will only go one way, you'll very quickly figure out which way it goes when you try and do it. And if you watch up on here, just go to main screen there, that art line, that red art line has now appeared. It wasn't there before. Once you're plugged into the correct place, that will automatically come up. Okay. So to zero it then, so we've just talked about the little airport there briefly, but to zero it, You don't need the patient for this part, and that's the best way I can sort of think of it, is for this bit you don't need the patient, you just need to know what atmospheric air is doing as such. So you would turn off to patient, so your little stopcock goes down towards the patient, that's off to patient and open to air, and this little one cap that was covering there needs to come off, okay? So now it's open to that air port and open to that little transducer, okay? Just can set that there because it's clean for a minute. And then on your screen, I'm not sure if you can see, Gavin, but there's the little 0 just down there. So in order to 0, if you press on that 0 there, you've got little choices along the bottom. Because we're plugged into the ART port at the back, it will give us the option to 0 ART. Press on that, 0 ART. And when you do that, the machinery will automatically, the monitor will automatically try to 0, and if you saw there's a little 0 very briefly came up. That's it zeroed, okay? You've got a 0, it's zeroed. It now knows what atmospheric air is doing. You've done that bit, okay? So you can replace your cap. All done there, okay? And once you've done that, then what you do is the reverse really. So that is now off to patient, off to air, sorry, and open to patient. You now need the patient in order to start monitoring blood pressure. And if I just take Christine's little outline here for the minute and just very briefly show you, okay, if I start to wiggle this a little, if you watch the little outline over here, you can actually see we're suddenly getting a little bit of pressure, and that's just sort of mimicking what might be happening in an artery. So you've got a little bit of pressure coming against the end of the outline there, which actually already is recording on the screen, and we can see something happen, and that's how that continuously monitors for us. We'll just get rid of the noise there. Lovely, I'll give you back your outline, Kristen. All right, thank you for that. So that takes a bit of the mystery out of the zeroing the outline, hopefully for you. That's literally all they're doing. And then from there on, you should be able to very carefully monitor the patient. The other thing I just want to talk about very briefly, and I'm not actually, in a sense, training you to do this at this stage, but I feel it's helpful to sort of understand as well the purpose of this syringe that is in this outline. And actually, we had an ITU doctor down the other day who wasn't quite sure how to use the syringe or what it was all about. And when I explained to her, it was essentially an enclosed system to hold the blood and saline, she understood exactly what we meant, and she was able to figure the rest of it out herself. So having some understanding, I think, is helpful for us all. To do that, I'm just going to actually pop it out of the little line again, just to show you a wee bit what happens with this. So if you have a look, because we took that extension set off, and that the reason that it just makes it a bit shorter and brings these little blood sampling ports closer to the patient really, which means you're more likely when you're taking the blood samples to just have pure blood. When they want to do this, what they want to do is to draw the saline away from because you're going to have some blood mixed with saline down this line, and you want to make sure that when they take samples from these little ports, all they're getting is blood. So at this point, to bring the blood back up into the syringe really, they will close off the stopcock to the transducer, okay, and then just using the syringe, drawing back on the syringe, will bring the saline in. If you were in the room, you would see the saline is coming back up the syringe, and if it was connected to Christine's artery, which it isn't, we would also be getting some blood coming back through now, okay? And if we kept going to the 10 mils, then you would have saline plus the 5 mils of blood, okay? The real advantage of these sets, and it is a brilliant thing, is when patients are critically unwell in ITU, every day there are very frequent blood draws, and when they have done this traditionally, they've had to waste this blood, so they've had to draw back, take back the saline, take back some blood. That blood then got wasted while the blood sampling was happening. With this enclosed system, that doesn't happen. Okay, this blood at the end of the blood draw will be returned to the patient, which saves them losing that sort of excess blood each day. There are 2 ports. ITU recommend we use this, or anyone doing it uses this closer port, so you can guide someone to that if they needed that. The only reason for a second one, I'm told, is for use in theatre, so it saves someone maybe ferreting away and underneath the covers and things to try and get at that closer port, but really the safer one is the closer one. Okay, and then once you have taken your blood samples, all of that saline and blood could be returned down the line again. And they could draw in a little bit extra to do their flush at that point, all right? And then when that's all done, you would turn off the syringe, back open to patient, and your monitoring would just continue as normal. Okay, just leave that there for a wee second. And the very final, actually pop it back in. The very final thing to have a quick chat about is labelling. It's really important that, so sorry, it's catching on there. Lovely. So it's really important that everybody in the room, and when they go to ITU, is aware of the fact that this is an ART line. It's not a normal fluid giving line. So we would recommend that you just pop these little arterial line labels, which are in the bottom drawer of your lines trolley, onto everything. So even just stick one on the bag is fine, one underneath your roller clamp, one wherever makes sense to you, and one certainly around the cannula dressing and around the bottom of the line, so everybody's very clear that an ART line is what you're looking after on this side or whatever. Okay, thank you very much.